cancer, and did gene expression studies, and this has already been published, but clearly showed that T cell infiltrates, or the lack of T cell infiltrates, were correlated with hypoxia gene signature. And obviously, when you have hypoxia, you have elevated levels of VEGF. So there's at least one rationale for putting these two approaches together, with the possibility that if you inhibited VEGF, you might attract T cells into the tumor microenvironment. And in fact, there was a second trial, which we also participated in. This was part of a bigger study, but this was a small cohort in renal cancer of 10 patients who got a dose of bevacizumab, and then it got a dose of bev plus atezolizumab in the second cycle. But after bev alone, and then after the combination, biopsies were done and compared to baseline. And to make a long story short, just bev alone increased, and you can see it here in the right-hand panel, increased a number of chemokines, which were T cell attractants in a tumor. So one rationale, obviously, of combining a VEGF receptor inhibitor is that it has immunologic function. It can bring T cells into the microenvironment. And then there was a randomized study that was done comparing, this was a randomized phase 2, comparing bevacizumab, atezolizumab, to atezolizumab alone, to sunitinib. And Genentech did pre- and post-treatment biopsies. The pre-treatment biopsies, those were then interrogated, and they came up with essentially 3 gene signatures. This was presented by Dave McDermott about a year ago, showing that you could divide up these tumors by having a T cell effector signature, an angiogenesis signature, a myeloid inflammatory signature. And you can see each one of those lines in the vertical direction represents one tumor, and you can see that some tumors have only an angiogenesis signature, some have combinations of these signatures. But what was interesting is that when they went back and looked at progression-free survival in these groups, it turned out that where bevacizumab was adding to atezo appeared to be in the group that had both a high T effector signature and a high myeloid signature here. And you can see that if you just had a T effector signature and a myeloid signature and you only got atezo, you did very poorly, worse than sunitinib in terms of PFS. But if you added atezo to bev in this subgroup, they appeared to do quite well. So perhaps having a myeloid inflammatory signature in the tumor might be a situation where a VEGF receptor inhibitor might help together with a PD-1, PD-L1 checkpoint inhibitor. And then this is just an example of data. The reason why I show these data is that there's very old data from sunitinib and a number of the small molecule VEGF receptor inhibitors that they can inhibit Tregs within the tumor microenvironment, reduce the number of Tregs, and even inhibit the function or migration of myeloid-derived suppressor cells into the tumor microenvironment. And you can see from this slide here that they're not all the same. So tivozanib here and sunitinib appeared to decrease the number of Tregs, where the others did not in this small sample size in these animal models. And so, but the point here to make is that they do other things, and that not all small molecule VEGF receptor inhibitors are the same. So the results that you might get with axitinib, nivo, might be different than what you might get with cabozantinib, nivo, for example. So some years ago, this was presented now almost 4 years ago at ASCO, looking at a phase 2 trial of combining, phase 2 trial of combining either Sutent with nivo or pazopanib with nivo. And I think you remember, most of you know these data. What I just want to point out is this was a particularly bad group of patients. Most of them had intermediate memorial risk category. Very few had favorable disease. Of the Sutent patients, of the 33 Sutent patients, 14 had prior therapy. All 20 of the patients who received pazopanib plus nivo had prior therapy. The other issue, the other thing that I want to point out is that this, and I'm not going to show the data, this group had higher levels of renal toxicity than one might anticipate, so this wasn't taken forward because of the renal toxicity. And the pazopanib nivo data showed higher than anticipated liver toxicity, elevations of transaminases. So at the time, that wasn't taken forward. But the response rates were remarkable. It's a 52% response rate in the Sutent group and a 45% response rate in the pazopanib group, really suggesting that there was at least additive activity and maybe synergistic activity for overall response rates. So the next important trial really was this randomized phase 3 trial that Bob Motzer just recently presented, in which treatment-naive patients who either had clear cell or sarcomatoid histology were randomized to get either atezo-bev or sunitinib. And these results were recently presented, and I'm just going to summarize it very quickly here. The analysis was complicated because it was both an investigator assessment and a central assessment for response and progression-free survival. But this is just the investigator assessment here, showing an improvement of progression-free survival in the primary endpoint in the PD-L1 positive group here, and there was a trend towards improved survival. This is a progression-free survival in the overall intent to treat patients, and the PFS intent to treat, and overall survival in the intent to treat patients. Nothing really here yet, and there's a trend here in the intent to treat population, but most of the effect appeared to be in the PD-L1 positive population. So there's been a number of small molecules that have combined with small molecule VEGF receptor inhibitors have been combined with either anti-PD-L1 or anti-PD-1. This study was presented by Tony Chowry, showing, again, this group, just I'm showing the demographics because I want to point out that this group was a little bit better than the ones that you saw that were treated with sunitinib-nivo or pazopanib-nivo. Most of these patients had a favorable risk category by MSKCC criteria. But again, remarkably, again, the response rates were high. It was in the 55% range. And you can see here that the PD-L1 positive group had a higher response rate than the PD-L1 negative group. Of course, we don't know what they would have done with just anti-PD-L1 alone or the VEGF receptor inhibitor alone. And we don't know, perhaps even these lower response rates might still be better than what you might see with either single agent. But again, a very high response rate with this group. And then there's a second trial that was presented by Mike Atkins just recently, combining axitinib with pembro. Again, a fairly good group of patients. Most of them had favorable, this time by the IMDC criteria, which, again, I think even a better group than the prior trial, because with the IMDC criteria, some of these favorable patients are shifted over into the intermediate category. But the response rate's remarkable, 73%, progression-free survival, 20.9 months. Almost everybody had some evidence of tumor shrinkage. So this is about as good a data as you'll get with combination. We still don't know what the durability of these responses are. And in this trial, there was no data on PD-L1 positive versus PD-L1 negative disease. So I made this little chart here for you just to show you the some of the complexities of trying to interpret the data. Because you can look at, if you're trying to look at subsets of patients, you can look by the IMDC criteria, you can look by MSKCC criteria, you can look by PD-L1 criteria, or you can combine the groups and say, what does an IMDC favorable group with PD-L1 positive or PD-L1 negative group do with each of these agents? And then you want to compare the combination of a VEGF receptor inhibitor with anti-PD-1 or anti-PD-L1 to what ipi-nivo might do in the same situation. Well, you'll hear more about that from Hans later. But I can't take you through all this in 10 minutes. It's incredibly complicated, and even I can't pick through it. But obviously, the ipi-nivo trial was mostly analyzed in the intermediate poor group for IMDC, and you can see here that it improved overall survival in both groups. However, better in the PD-L1 positive group, and it's clear that the PD-L1 positive group, if you look at the curves, have a poor prognosis in the PD-L1 negative group. But if you look at the PD-L1 positive group in this trial, actually Sutent beat ipi-nivo here, had a higher response rate, higher progression-free survival. There's no survival data yet. If you look at the atezo-bev trial and you look at the hazard ratios for progression-free survival by IMDC groups, it was a positive survival. This is probably not statistically significant, of course, because these were smaller numbers, but hazard ratios were going in the right directions for all three groups if you were PD-L1 positive. Okay, so again, gets very confusing. And the reason why I bring this up is that at some point in the future, we may want to divide up patients by whether they're IMDC favorable, intermediate, poor, whether they're PD-L1 positive or not, and choose whether we give them ipi-nivo or a VEGF receptor nivo based on which of those subgroups they fall into. There are other combinations which you heard about before, tivozanib and nivolumab, a large phase 2 trial was done. There were only preliminary results, so I didn't feel like I needed to present them here. There's already a phase 3 trial of Avantinib, pembrolizumab, ongoing, and you heard about the Cabo-Nivo and the triplet combination phase 3 trial earlier on. So just a few conclusions. Combinations of immune checkpoint inhibitors and VEGF receptor inhibitors really do result in improved activity. I mean, we don't have a randomized trial yet, but whatever little data we have certainly suggests that it's going in that direction. My guess is that it'll improve overall response rates and PFS and maybe even survival compared to a VEGF receptor inhibitor alone, and possibly compared to anti-PD-1 alone or anti-PD-L1 alone. We still don't know the durability of the response and the ability to maintain that response off of therapy. I don't think the immunologic effects of all the VEGF receptor inhibitors, especially when you're comparing bevacizumab to the small molecules and the small molecules to each other, are the same. So if there is a possibility that the outcomes might be different depending on which drug you use. Certainly don't want to use pazopanib because it causes liver toxicity. I can tell you I've used Sutent a lot in the clinic together with anti-PD-1 and have not seen the sorts of toxicities that were reported in the initial trial. And of course, the receptor tyrosine kinase inhibitors of small molecules have higher response rates compared to Bev, and in the combination also have higher response rates, but the tox may be greater. And then again, because we want to pick the right patient populations for the right combinations, it's really important to compare apples to apples. And so whether we use the Motor criteria or the IMDC classification, whether they're PD-L1 positive or negative, will really be important to go back and look at those subsets to see which groups are really benefiting from which combinations. And just a few other things, the PD-L1 positive tumors have worse outcomes, but PD-L1 really is predictive for better outcome. It looks like both to the immune checkpoint inhibitors and to the combination with VEGF receptor inhibitors. The IMDC favorable group, at least in the Checkmate 214 trial, most of those patients were PD-L1 negative, and that may explain why Sutent had a higher response rate and why Ipi-Nivo looked worse. I think, again, you need to use these for, I think, to select patients, and I've made some suggestions here, but we can discuss that later. Right now in the clinic, I probably would offer the VEGF receptor immune checkpoint inhibitor combination after an IO-IO combination, but that's a bias and not based on pure data. And then there's the importance of incorporating these other biomarkers like myeloid cell gene signatures and adding that to IMDC scores and PD-L1. Maybe we might be able to get a better idea of which subsets will benefit from which therapies. So I'll stop there and happy to answer any questions.
So why not? So this is great talk with Dr. Sznol. This is so why not using VEGF I plus IO combination for intermediate or poor risk patients who are PD-L1 negative, knowing that progression-free survival data was not impressive at all, and overall survival, we'll see how the, I know hazard ratio is 0.73, but it was a lot more remarkable in PD-L1 positive patients. So I think VEGF TKI plus IO combinations are going to be more impressive in those groups.
It may be, but I don't know. And I've twisted myself into knots trying to go back to all the data and see if I could figure out which subgroups would get which combinations based on both IMDC scores and PD-L1 scores. So you're right. In the IMDC poor intermediate group, who are PD-L1 negative, you might give a VEGF receptor inhibitor plus Nivo. On the other hand, survival was also improved in that group with Ipi-Nivo versus Sutent. So right now, the only survival data that we have in that group is with Ipi-Nivo, and in that group, Ipi-Nivo was better than Sutent.
So, right now.
Right now. No, in the future, it can. And I think when we do randomized trials in the future, we really need to start breaking patients down by these categories because they clearly are predictive to some degree for a response. But no one gives you all the data, so you can't compare. It's comparing apples to oranges constantly in these trials.
I thought the data at the very beginning, the fascinating with the myeloid inflammatory gene expression profile. How reproducible is that from biopsy to biopsy? So, in other words, do we know again, as we've learned the genomic heterogeneity, is there signature heterogeneity within a tumor? So I biopsy the lung and I get it as a non-myeloid, and do we know that at all?
The answer is I don't know, because I don't know that I don't know of anybody who's taken two. I mean, there was data on taking renal cell cancers from two different areas and showing very different numbers of mutations.
Correct.
But whether one looks at a gene signature, my guess is that there will be differences, because not in renal cancer, but in melanoma, my other favorite disease, you can certainly look at different regions of the tumor and show different levels of T cell infiltration. So certainly if you were to do gene signature studies, in some parts of the tumor you probably see no inflammatory signatures, and others you would. Whether the myeloid cell compartment is the same in all of those, I just don't know.
Do you think that with these high response rates, are you thinking it's ready for considering some adjuvant therapy trials?
So that's a great question. And when we talked about adjuvant therapy earlier on, the first thing that came to my mind is maybe once we're done with the anti-PD-1 alone trials, and there's an ipi-nivo trial also, that the next step might be to think about doing VEGFR plus immune checkpoint inhibitor trials. But I sure would like to do those trials, having more data on these categories of which patient does best with which. That might actually help us to design that adjuvant study with a VEGF receptor inhibitor a little bit more rationally.